Hello, this is Jeff Weiscarver, and I'll be talking today about screening for bruxism and related sleep issues. And I also wanted to take a moment to thank Dr. Jameson Spencer for allowing me to present on this topic. Sleep bruxism, let's talk about the definition first. I use the research done by Dr. Levine and his article and research published in 1996, in which he defines some of the events that make up sleep bruxism. There's a clinch defined as a 1 EMG burst lasting anywhere from a quarter second but less than 2 seconds. There's RMMA, rhythmic masticatory muscle activity or activation, and that consists of at least 3 EMG bursts or more, each lasting a quarter second but also less than 2 seconds. And then there's a grind, which is a combination of both those types of events, and all those would be good to confirm with audio and/or video evident. And RMMA looks something like this. So this is let's see, a 3-minute window, and you can see the RMA there in the center. Here's a clench, something like what you would imagine it to look like. And here's a grind. The hallmark feature of a grind is its duration. It's typically much longer than the other two types of events. Now that we've defined bruxism, let's talk about parafunction. So bruxism has those 3 events that we just defined. And then there's EMG activity that don't fall into one of those 3 categories, but nonetheless, it's EMG activity that occur during sleep. And so when we include bruxism with those events, all those equal parafunction. And so I wanted to make sure that from now on, I'm going to be talking about parafunction. Okay, what is parafunction? It's EEG arousals, and then a cascade of events occurs, and one of the events in this chain is there's a trigger of EMG activity. And so what we're talking about here is an EEG arousal, and then there's a series of events, and we're going to talk about one of the triggers of EEG arousals, and the most common is sleep disordered breathing. So for the rest of the presentation, we're going to talk about sleep disordered breathing and the consequence of that EEG arousal. So here we're going to talk about airway issues, and I'm going to talk about that in the context first. We have a 1.5-minute window here, and there's 6 stages of this airway. And I'm going to point out that at each stage, an EEG arousal and subsequent parafunctional event can occur. So the first stage here is flow limitation, and that's marked here by a series of breaths tagged with a little orange box. And what happens here is the airway aperture at some point gets smaller, and when you're inhaling and you're expecting a certain amount of flow, and because of the reduced airway or reduced size of the aperture, we create a negative pressure on the inside of the airway. And when you get that negative pressure, we're going to go to stage 2, and we're drawing in the soft tissue. And stage 2 is snoring. It's the bottom channel here, and you can see spikes that indicate snoring. And this is crescendo snoring, so each spike is getting higher and higher, meaning it's getting louder and louder. So then we're going to move on to phase 3. And phase 3 is the sum of the first 2 issues. Okay, so we have flow limitation and snoring. And as a result of those 2, stage 3 is a work of breathing or respiratory effort. And when we talk about respiratory effort related arousals, this is where we can start measuring for that. And you see that rising at stage 3. Stage 4 is where we go into a hypopnea. And hypopnea is well known. It's the respiratory event. It's the H in AHI. And we can see that we have a hypopnea here at phase 4, along with number 5, which is a oxygen desaturation. And then number 6 here, we have the termination of the respiratory event with a clench. So this is kind of the progression or the degradation of an airway. And next we're going to talk about, remember I mentioned that we can get a parafunctional event at any phase of that. And here we have a series of events of flow limited breathing with no oxygen desaturation, but we do have a clench, and this clench is about a second long, so it's greater than a quarter second but less than 2 seconds. And we did get the audio of this clinch. So that's kind of an interesting event there. Now we're going to zoom out and we're going to look at 30 minutes. And you can see the amount of parafunctional activity here. So I wanted to kind of show this from two perspectives. One perspective is for the dental sleep medicine specialists out there. You're looking at the apneas and hypopneas. And you say, wow, this is a severe patient. You'd be right. And the TMJ specialist or TMJD specialist or the pain specialist is looking at all this EMG activity. And the point is, this is 30 minutes. This occurs every night, all night. So you can imagine how, based on your perspective, how the patient comes up symptomatic. Next, I'm going to shift gears on you a little bit, and we're going to talk about protective strategies. This is more for the TMJ general dentist, TMJD specialist, general dentist, the pain specialist. So when we did this pilot study, and this is 14 subjects, so it's a very small n, these are 14 patients that have been given a guard to either manage pain or protect dentition. Okay, so what we did is we monitored several parameters as a baseline, and then when they're wearing the guard, for the purpose of determining what effect that protective strategy or treatment had on the airway. So like on subject 14, the HI started at 0.8 and went to 1, and that's a great outcome. So we have an effective treatment that didn't have a negative impact on the airway. But if we look at like subject 8, where we started with an AHI of 13 and wearing, it's an upper guard, it looks like, we have an AHI with the guard of 25. So we almost doubled the AHI. And I would ask that, is that a fair trade to protect the dentition? So probably most of us would probably agree no. The idea here is, and the concept is, we just want to illustrate the importance of knowing what your therapy has on the airway when it's not a sleep apnea appliance. Okay, so this is the issue. And now we're going to talk about a way to monitor these issues with a device called the GEM Pro. And the GEM Pro is a dental test unit. It is not a home sleep monitor. It doesn't give an AHI. It's not a diagnostic instrument. Physicians don't look at this data. This is for a dentist to take a snapshot and determine, okay, what are we actually dealing with, especially in patients with tooth wear, and maybe they want to fix their smile, or maybe they come in complaining of snoring. Maybe it's not an obvious sleep apnea issue, or maybe you're not a dental sleep medicine specialist, but still the airway may have an impact on what you plan on doing with your patient. So the GEM Pro is designed for those scenarios, and it's an oximeter. It's an EMG amplifier. We put a sensor on the masseter, and then there's a snoring microphone and a body position sensor. And the patient wears those two devices while they sleep, the oximeter and the amp, and it transmits the data via Bluetooth to a tablet that's somewhere in the patient's house. So, and then in the morning, the tablet generates this nice report, and we're going to talk about those reports now. You can see here there's a number of graphs you get. You get SpO2 graph, heart rate graph, bruxism analysis, and I'll talk in some detail about that. And then we have a snore or an audio signal. And we call it an audio signal for a reason and not a snore signal. It's very interesting there. Okay, let's talk about EMG signal. And the GEM Pro delivers information both on frequency and magnitude. What's interesting about the magnitude is we do not have any type of pressure sensor in there. So people wonder, how can you tell how strong the clenches is? And this is how. We do a biocal before you go to sleep, and in that biocal, the tablet will ask the patient, bite down as hard as you can and relax. And we do several of those. And then we capture the strongest waking bite force. And then we compare that strongest waking bite force to what the forces are that are exerted when the patient's sleeping. And then we deliver a ratio to that. Okay? So if your ratio is 1, that is, you can bite down as hard as you can when you're awake, and is when you sleep, that's 1. That's abnormal. A 2 is moderate. Okay, so that means that you're biting down twice as hard when you're asleep as when you're asked to bite down when you're awake. And 3 is severe. meaning 3 times as hard when you're asleep. So here's our graph. And again, the color of the graph is body position. Red is on your back, and blue and green are on your sides, yellow is on your stomach. In this patient, we have a waking bite force, biocal max force of 102, and a night max force of 105. And I selected this graph because they're about equal, and it yielded pretty much a 1 that you see there in the right-hand corner. Along the bottom of the graph, we have the frequency. So we start with really weak events on the left, 133, and as we go to the respective boxes down through the graph, each of those boxes represents stronger and stronger parafunctional events. Okay, so we quantify the events and put them in buckets based on their strength. Okay, and then the bottom graph there is the calibration. All right, let's take a look at a report. This is a report on somebody who has a normal airway, as indicated by no desats, no oxygen desaturations, and no snoring, and no complaint. This is a patient with wear and really has no complaint related to sleep. And we see that they do indeed have significant parafunctional activity when they're asleep. So this is a true bruxism patient. By the way, this is fairly rare. Typically, we'll see some amount of airway issue associated with bruxism this severe. So what makes this patient severe is if you look at the bruxism graph, the third one down, their ratio is 5.78. So remember, 3 is severe, so they're past severe. And their frequency along the bottom, those are very high numbers. So this is a patient that you would probably, whatever you would do for a normal patient that doesn't, or a normal patient that has a complaint related to their tooth wear or pain, whatever you would do for that patient, you could do this and not necessarily be concerned about their airway. But I would highly recommend that once you treat them in whatever manner you feel is appropriate, do another GenPro study to make sure that the airway is maintained. Probably is, but just to make sure. And then also you can see an improvement in the bruxism numbers. So you'll see a tremendous reduction in the force and also a reduction in the frequency. On this next patient, this is a classic sleep apnea patient. So regardless of if you're a general dentist, a pain specialist, or a dental sleep medicine specialist, this is a pretty straightforward case. You put this patient in your medical pipeline, get them seen by a physician, get them diagnosed by a physician, and take care of them that way. I did want to talk for just a moment about if you're not a dental sleep medicine specialist, and let's say you like the idea of the GenPro and you get yourself one and you get a study like this that has really severe desats and their complaint has nothing to do with their sleep apnea. This is a good outcome because we need to get this patient seen by a physician. There's no question. This is a very sick patient. And with regards to their dental complaint, be a dentist. Do whatever it is, address the dental concern, but make special effort, especially when they're this severe, to get the patient in to see a physician. It's really, really important. And the patient will thank you for it. Snoring is not a medical issue, nor is it really a dental issue. No one pays to treat snoring except patients. And luckily, that's the thing that patients are probably most willing to pay to get treated on. And just, this is the top graph here is a positional snoring patient. And interestingly, gray means on the graph, on that gray part, that means that you're on your back, but you're propped up 30 degrees or more. And you can see that's fairly effective. And when they go flat, which is when it's red, you can see that the patient snores, significantly. And then they prop themselves back up and the snoring goes away. So great outcome. We can tell the patient, listen, let's get you into a guard, or you can say, make sure that you keep yourself propped up, whatever is the most appropriate for your patient. The middle graph here, the audio is a normal graph. And then the third one is a dentist that just wanted to do a study on themselves, and that's the worst snore graph of thousands of these GenPro reports, because I get a copy of every single report that anyone does, and this was the worst one I've seen, and it was dentist, so that's pretty cool. Another cool feature, we call it audio analysis, because if you don't snore and you clench or grind, we can hear it, and this is not a duplicate graph. The top part of the graph is the bruxism, and the bottom part's the audio. So I just thought that was a cool comparison. Next here, the main point here is to do a Gym Pro study, do something, and then do another one to make sure that whatever you did has the expected outcome. And in this case, we had a severe bruxer. Their ratio was about 4. We made them a guard. Their ratio went to 0.5, so we dramatically reduced the magnitude. And you can look at the frequencies. I mean, we were in the 60s and 70s, events per night down to 2. So that's awesome. That was a tremendous outcome. And patients respond to this. You show them, hey, look how good you do when you wear your guard. It gets them motivated, especially if you explain that if you don't wear the guard, this is how you get repetitive work in, damaged crowns and bridges and so forth. We can avoid a lot of that or slow the progression of that down if you're compliant with your therapy there. And then finally, this is a sleep apnea patient. So this is more for the dental sleep medicine specialist. And we can see that we did a baseline. We ended up getting this patient diagnosed down the medical path, whatever path that this dentist had. I believe they subscribe to a service that sends an HST unit to their house on behalf of a physician. But what we learned before that occurred is that the patient had a tremendous amount of parafunction and that they only slept on their back. That's a little bit weird. Or not weird. It's unusual. It's rare. We see enough of these, and you'll know that it's rare that somebody spends a whole night on their back. But in any event, on top of getting the patient diagnosed, which if you just had an oximeter and you did this, you would have done the same thing, but you would not have known that the patient only sleeps on their back and that they have terrible parafunction. Okay, and they sleep on their back for a reason. And now that you know that, you're armed with 2 bits of information you would have ordinarily have. They sleep only on their back and they have really bad parafunction. So in this case, instead of going with like an EMA or a silent night or some type of appliance like that, the dentist went with a Panthera, which is made of that kind of nylon material. I don't know if it's nylon, but it's really strong material, and it's a great apnea appliance as well. So this is my presentation. I wanted to mention that the Gym Pro, if you're interested in, I'd love to hear from you. They retail for $1,900. If you give me a call and say you watched this, I'll definitely give you a discount. We don't charge for software. We don't charge for reports. Once you own the unit, you own the unit. I look forward to hearing from you. Thank you.